Thank you everybody for coming, and this session on complex strabismus is covering both the east and the western hemisphere, the northern and the southern hemisphere. So I am actually very grateful for this galaxy of speakers that have agreed to be part of this course on complex strabismus, and we will be covering a lot of these topics which are challenging to say the least. But besides this, we hope we will have some adequate time at the end of the talks, and we may take a couple of questions in the middle, but we hope to have some adequate time in the end where we could take up some questions and discuss directly. So that's the aim, and thank you very much. I am Professor Rohit Saxena, and I'm from India. I have my co-instructors for this, Dr. Saurabh Jain from UK, Dr. Andrea Molinari from Ecuador, Dr. Angkor Wang from Chinese Taipei, Dr. Rahul Bhola from USA, and Dr. Swati Fuljule, a colleague with me at RP Center, India. So I'll start with my talk first, which is managing Duane syndrome, and then we'll move from there. So Duane syndrome can be quite a challenge because, as we will see, there are so many issues which we are yet to understand. I have no conflict of interest to disclose. The first thing is the unusual thing about the pathophysiology of Duane syndrome. It's not something that we can so easily understand and relate to. The start of the problem is that there is nil or subnormal innervation to the lateral rectus from the sixth nerve nucleus. So there is subnormal innervation. It starts off with a kind of a palsy. However, the lateral rectus gets some abnormal innervation from the medial rectus subnucleus of the third nerve. This not only results in an abnormal firing of the lateral rectus or involvement or activity of the lateral rectus, but also theoretically, if you look at it, there is a subnormal MR or medial rectus innervation. Essentially, what we understand when we use the term subnormal innervation to a muscle actually means that it's a peretic or a palsied muscle. We don't conceptualize this when we're talking about a Duane syndrome, but we'll realize that the lot of features that we see and the huge variability that we are seeing is somewhat related to these changes. And of course, over time, there are secondary muscle changes with medial rectus undergoing fibrosis. And again, the question is, why should the medial rectus undergo fibrosis? It is a very common feature for you to see that the force duction test is positive, and I have experienced the force duction test for the medial rectus to be positive, not only in isoduans, where it kind of explains itself, but also even in exoduans. So you'll realize that there is an abduction deficit or defect in exoduans also. The reason why this is happening is our understanding of the fact that subnormal MR innervation to a muscle fiber results in the fibrosis of that muscle fiber. So the muscle fibers or the myofibrils that are not getting innervation because of those nerves being transferred to the lateral rectus will eventually result in fibrotic changes in those muscles, and that is why we will keep seeing a bit of a tightness of abduction or a force duction test being positive for almost all patients or all grades of Duane's. So the pathophysiology is this, but the variability that we'll be seeing is huge because of the variability in the amount of nerve fibers getting transferred and the manifestations of abnormal innervation and subnormal innervation. This limits our ability. We are actually tackling a neurological problem by a mechanical change of muscles and trying to adjust for that. So our aims are limited. Our achievement, what we can achieve is modest. So our aims are to reduce the deviation in primary position, to eliminate, if possible, an abnormal head posture, disfiguring retraction, or shoots. We just run through with some cases, and I'll just try and run through all the various cases that we can see. So this was a young girl who came to us. Again, the characteristic thing for you to notice when you're looking at Duane's is they have good vision and they often have very good binocularity. This is because the amount of deviation usually is less, and the child is able to develop with the head posture, maintaining binocularity, and in many cases, very good stereopsis. So here you can see this is a patient of, can I get a marker, please? So here you can see a left iso Duane's, a small angle esotropia, a small narrowing on adduction, and on abduction you can see the widening. So this is a mild aspect of a Duans. The deviation is not so much. So how do we approach an ESO-Duans? You look for it whether it's unilateral or bilateral. A small angle deviation in primary position, you can do modest amount of surgeries. A little larger amount of deviation, you plan for a little larger surgery. We'll discuss the options. And of course, when there is co-contraction, you need to tackle the bad boy of the class, which is the lateral rectus, and try and see how we can minimize the complications and problems causing. And of course, bilateral Duans would require bilateral intervention. So in this girl of ESO-Duans, we did mild amount of MR recession. 5 mm recession is actually very large for a Duans. The reason why I say this, that while we get very good primary gaze alignment, you can see the adduction deficit that you will create. This adduction deficit is abnormally significant for a small 5 mm recession, which we are used to in comitant squints. And why does this occur? As I mentioned earlier, we are weakening an already weakened muscle. Besides the innervational abnormality here, you have the lateral rectus also that is firing at this time and is preventing the adduction from happening. So this is the important thing when you are deciding on ESO-Duans. Do not do large ipsilateral MR recessions in unilateral Duans. It will result in adduction limitations, and if the retraction is severe, you may actually see simultaneous abduction. You may actually have a synergistic divergence kind of an appearance. Titrate the MR recession based more on the FDT. Your aim is to free the FDT. Let's look at this girl. You can see the deviation is much larger. Again, she was able to get good binocularity and stereopsis, although the abduction limitation is very severe, but she had a good head posture, which she was able to manage. Now, let's see what our aim would be in this. So we stuck with doing a very small medial rectus recession. The aim was to ensure that the abduction is free, but we also did a muscle transposition procedure to augment. So you can see an improvement in the abduction that you are able to get. So advantages of transposition is you get greater abduction versus recession alone, less medial rectus recession is required, so you have less adduction limitations, and possibly you may have less post-op recurrence of esotropia. Do not do transpositions if you have severe retraction, because you're going to worsen the retraction. There are a lot of procedures, VRTs, SRTs, inferior rectus transpositions. We have different experiences with that, but of course, we find modified Nishida to be a little less effective than the full muscle transposition. So maybe it's better for Duans only rather than 6 nerve palsies, where we need to correct a larger deviation. I think we're still looking at effects of these muscle procedures to know more. People have described lateral rectus resections in ESO-Duans. Be careful. Nothing is never or banned in medical profession, but only do if there is very little co-contractions, and do very mild amounts for correcting the ESO. Otherwise, really not. I personally have probably done a resection in only one case till now of all the Duans that I have managed. This is a case of bilateral Duans. He had alternate face turn, and of course, FDTs were positive both sides. He was alternating face turn, so he had good vision either eye. We did bilateral medial rectus recessions to get alignment. Of course, abduction limitations were enough. If the deviation was larger, I would have probably added a muscle transposition, an SRT or a half VRT to the MR recessions to tackle the deviation. I would have then tended to do one at a time so that I would have known how much to correct for the second eye. You have an ESO-Duans with retraction. You can see there is severe retraction. Now here comes the complication. You need to tackle the LR also. So you will recess both the medial rectus and the lateral rectus. This medial rectus we put on an adjustable so that we could get a little better esotropia correction. But again, you need to titrate that with the adduction limitation. EXO-Duans is now a completely different management problem, because sometimes they can be really disfiguring. So here you can see the EXO-Duans, and the contraction is so severe the eye has actually disappeared. Now, what are our options in EXO-Duans? If there is no retraction or shoots, normal or subnormal LR activity, you can get away with just an LR recession. You have shoots, you need to weaken it even further. So if the LR activity is normal, I would do a little larger recession with Y-split. However, if there is significant subnormal activity of the LR, that means that the LR is also not functioning appropriately. I could probably do a periosteal fixation because I'm not really needing the LR because it's not providing any abduction. So I'm not losing so much if I'm completely eliminating the LR. So in this case, we did a periosteal fixation, and you can see good alignment and almost entirely the retraction and the abnormal movement is gone. Of course, you lose the abduction, which is there. Now, this was another patient of exoduans. You can see again severe retraction with shoot. We did with the periosteal fixation along with a vertical rectus transposition, a partial VRT, so that we do not cause an esotropia. So when would I want to add a muscle transposition to a complete elimination of my lateral rectus? When I have some lateral rectus function to start with. You can see there is hardly any lateral rectus function here, but in this case there is good lateral rectus function. So there is a high risk that if I just do eliminate my lateral rectus and do a periosteal fixation, I may develop a consecutive esotropia. So I need to do a transposition procedure along with that. Remember, all these hypertropias and primary gaze may not be due to a superior rectus or a vertical rectus involvement. Here you have done, I've just done a periosteal fixation, and you can see there is no hypertropia in primary gaze. You may not need SR recession. Check the force duction test after you have disinserted the lateral rectus, a force duction test for superior rectus. If it is tight, only then you will require an SR recession. Possibly the severe hypertropia in primary position is just a part of the retraction of or the abnormal co-contraction of the lateral rectus even in primary position. So always don't worry about it. And orthodontals, really do not think of doing any surgery, because I don't think you can do any better than what she is now. So if in orthodontals, if you have co-contractions, you have retractions, you need to tackle that. If you don't have any of these abnormalities, you probably do not need to do anything. So associated retractions or shoots, you will have to tackle both the medial rectus and the lateral rectus, and ensuring that you do not have any kind of consecutive esotropias, exotropias, or any abnormal position. So the messages I would like to highlight is, be clear of the indication of surgery. Normal ductions and versions cannot be achieved. Please tell that to your patient before operation, because in the end, after the surgery, the patient expects to be absolutely perfect and to be the next model on the next cover magazine. So please remember that. Our aim is to get primary gaze alignment, increase as much as possible the area of binocular single vision, eliminate disfiguring shoots and retractions, or at least decrease them to our best ability. Thank you very much for the opportunity, and I think we'll go on to the next speaker. In the meantime, any quick questions we want to take? And can I ask all the speakers also to please come up on the dais? I'm sorry I didn't do that in the beginning. Dr. Saurabh Jain will be our next speaker, Dr. Andrea Molinari, Dr. Angor Wang, Dr. Rahul Bhola, and Dr. Swati. Can please come on the dais, join me on the dais here.
Is there time for one quick question?
Yes.
Oh, that was a fantastic talk, thank you so much. I just wanted to ask you, do you have much experience using botulinum toxin in Dwayne? I find in my practice it has very little effect.
No, I did not. I haven't tried it. And again, the reason is that, like I mentioned, that I believe that the MR is almost always tight. So I need to recess it to release the FDT to get any effect on the deviation. So thank you. Our next speaker will be Dr. Saurabh Jain. I'm sorry, this is the list. You'll have the list in front of you. Dr. Saurabh is a professor of ophthalmology at the UCL Medical School and ophthalmic surgeon at the Royal Free London NHS Foundation Trust. He's an expert at pediatric ophthalmology and adult strabismus. He will probably be dwelling on the role of botulinum toxin in strabismus. So, Dr. Saurabh, please.
Thank you very much, Prof. Saxena, for inviting me. And sorry, sorry, Rahul, to have displaced you, but that's not new. So Rahul used to be my first year PG, so I've been displacing him a long time. So poor thing's used to it. So thank you so much for inviting me. It's a real pleasure to be here back in Delhi. I'm going to talk a little bit about Botox and strabismus. It's something that we started using quite a lot of, and it's one of those things, once you make it, they come. So we're finding more and more indications of using Botox in strabismus, and I want to share some with you. So a little bit of pharmacology, that I'm sure you're aware of, is an exotoxin. It was first tried by Alan Scott in San Francisco in 1980. John Lee brought it to the UK, literally in his coat pocket through Heathrow, and he started the Botox clinic at Morphill, which is now the largest Botox clinic in the world. And at the moment, it's licensed by the FDA for all these conditions in more than 12 years of age, although we do use it off license in children for a few things which I will talk about. So the Botox is a big molecule that is cleaved to form the active toxin, and this active toxin essentially inhibits the release of acetylcholine, which causes its effect. So it causes a weakening of the muscle, which causes the effects. So there are various forms of toxin. I use Botox because I was trained in Manchester. That's what we used then. But we also use Dysport or Xeomin. The difference is the dosage. So for the Botox, I use no more than 5 units at the max, maybe mostly 2.5. Problem is there's no dose response curve, which would be great. So it's not like if you put 2.5 units, you'll get this much effect. So as a general rule of thumb, strabismus that's less than 30 diopter, we use 2.5. More than 30, we tend to use 5 units. I use an EMG guidance because I think in this day and age, you absolutely have to. The onset of clinical effect, and this is really important, you have to tell the patients nothing will happen today. It will start working over the weekend, and you will peak around 2 to 3 weeks. So on the whole, we do the toxin, and then we see them in about 2 or 3 weeks afterwards to look at the response. The effect on the whole lasts around 3 months. It can go on a bit longer depending on what indication you're using it for. So for example, if you are correcting the sensory, if you're trying to reignite the sensory fusion mechanisms, you can have a much longer impact of strabismus. We reconstitute with saline. I say to all my fellows, do not shake it, because apparently if you shake it, you denature it. So just a bottle of toxin, we put 4 ml in 100 units, that gives you 2.5 units per 0.1 ml. The key thing is this 0.1 ml. Whatever you inject, whatever dose you use, you have to try and inject it within 0.1 ml because you want it to work on the muscle using it for and not anything else. Okay. So you can use it in children or in adults, and the indications are a bit different. So in children, we use it in congenital infantile esotropia, kids with developmental delay. We just had a great session on esotropia, or acute acquired esotropia, and a residual consecutive strabismus. In adults, we use them in 2 kinds of scenarios, either as a diagnostic tool. So you're about to correct strabismus, you want to see what the impact will be, or you have corrected it and you have residual or consecutive strabismus. So you can use it diagnostically or therapeutically. So the advantage of toxin is a non-invasive technique, right? So you preserve the anatomical features, there's no scarring, there's no risk of anti-segment ischemia, there's very low risk of glow perforation. In my career, I've had one person who had a glow perforation, and this person had multiple previous surgeries and was a high myopia. It does happen, but on the whole, if you use EMG guidance, it's quite rare. And if you're doing it in a child, you can do it much shorter anesthesia without the need for intubation. However, you do delay the attainment of orthotropia. This is, as I said to my patients, it's a bit like using a hammer when you should be using a screwdriver. So you can get quite unusual results. So you have to prepare people for that. You prepare people for ptosis. You have to prepare people for the fact they may have a red eye. So don't do it just before they're about to go in for a wedding or a big conference speech or whatever, because that might be something to think about. And of course, you don't want to. You want to include in your consent form the adverse effects of local spread like vertical strabismus and even mydriasis. These are some of the kids and adults have done. So these are some of the side effects of ptosis. On the whole, ptosis is rare in adults, less than 10% in my hands, kids up to 20%, and one of the ways to avoid it is either to use a special forceps like the Mendonca forceps, or Dr. Doniso showed us one of his own this morning, or you sit them up. As soon as you've done the toxin under anesthesia, leave the needle in for at least 60 seconds by the clock and get them sat up as soon as possible, and that really reduces it. Warn the parents about the risk of consecutive exotropia. I always say to them, you will see the eyes go out. It's a bit like resetting the system, so don't worry. And of course, some conj hemorrhage, in some case, retrobulbar hemorrhage. And there's one case report on tonic pupil following toxin injection that resolved with pilocarpine. So I'm just going to present two cases very quickly. I've got 4 minutes, so I should be okay. This is a common situation. 8-month-old boy, large angle esotropia, palatal infraoblique overaction, no hypermetropia. It's an infantile esotrope. So what are we going to do? So there's a lot of controversy. We just talked about it, but I quote this paper all the time. This is from Alejandra Campomanes, the largest randomized control trial, to the best of my knowledge, on looking at toxin versus surgery in patients with strabismus. The groups were not equal because they never can be in strabismus, and the toxin group was younger. However, and she used quite hefty doses, 5 units or 7.5 units. And what she found essentially, so these are the two groups, you can see they're matched in everything apart from age at presentation, where the toxin group is significantly younger. Okay, and essentially it all boils down to this. If your deviation is more than 30 diopter, you're probably better off having an operation. If it's less than 30 diopter though, toxin is equivalent, and something to think about. We still use it in some children who may have a very large angle esotropia, like 70, 80 diopters. You can say, well, we can do it during surgery or before surgery, try and reduce the angle, so we might get away with doing 2 instead of 3 muscles. So there is a bit of an indication there as well. This is just, let me just reduce the. This is how I do it. You can use EMG guidance, which I do because more for proprioception, to be honest. We don't really get a signal when they are asleep. But now we talked about forceps, so you can use a forceps too. Once you've done enough of these, I have to say the proprioception is quite good, so you know you're in the right place. The key is once you've injected, keep it in for 60 seconds. And that is there's such a precedence to just finish and get to the next case. Don't do it, and get them set up. So what it looks like 2 weeks later. This is the child I showed you before. You want to see this exotropia, otherwise it won't work. This is another case, pre-toxin, and this is I think a year or so post-toxin. We also published this paper that talked about using toxin in children with cerebral palsy, because as we know, a lot of these kids develop consecutive exotropia as they get older. So you really you don't want to operate and have to undo your operation. However, a lot of these parents will tell you, my child already has developmental delay. They're treated differently in school. Can you do something about their eyes at least so they don't look like they have esotropia? So we saw quite a few of these kids and they did really well. This is Matthew, one of my youngest patients, and this is him at presentations about 6 months of age. This is him at 2 years of age. He's done really well following just 1 injection of toxin. You can see the ptosis in the second picture with the chin up head posture. And this is my last case. This is a 14-year-old girl with an acute onset of esotropia. We talked about this a little bit, acute onset of esotropia that's non-accommodative, and ANAET, and we found her vision was fine, but she has this acute moderate alternating esotropia with diplopia with no lateral concomitants, and almost same for near and distance. So this is the Buren-Franceschi type of acute acquired concomitant esotropia, and she had bilateral medial rectus toxin, 2.5 units. And the reason we use this in this girl was that we really needed to get on and do something to restore her binocularity as soon as possible. She did really well. She had complete resolution of the esotropia, so discharge after 2 years, and we have also published a series of cyclical esotropia that have done very well with toxin. So just think of toxin as a alternative when you have strabismus that is acute onset, strabismus that is unpredictable, or where you just want to manage the consequences of your surgery when you haven't got the result that you need. And this is a fantastic ophthalmology technological assessment report by Stacy Pinellas and groups that you might want to read. Thank you very much.
Thank you, Saurabh. A wonderful presentation as always. Thank you very much. Any questions? Quick question before a comment, yeah?
So my experience is it doesn't work. I'm sorry. I've tried it, and in an acute thyroid, you really want something to work, and I've done it in a girl with huge ET, really upset, very, very symptomatic, big vascular muscles, and I think it's because the muscles have changed. It's the same as Botox in Duane's.
Yes.
It may work, but the muscles are not the same. They're not these elastic bands, so you get a very unusual response. Sometimes no response, sometimes a little. Apparently it does. Okay, and the theory is that, because you put it in and it modifies the muscles, it makes them less fibrotic because it relaxes them. It depends at what stage you see them, but I found that if you see them in the tight contractile fibrosed muscles, they don't do very much for me.
Thank you. And our next speaker is Dr. Andrea Molinari. She's the Director of Fellowship in Pediatric Ophthalmology and Strabismus at the Fundación Metro Fraternidad, I hope I get that right, in the Central University of Ecuador. She is the president of the International Strabismological Association, a great and fantastic strabismologist. She'll be speaking to us on strabismus and myopia.
Thank you, Dr. Saxena, for having me in this session today. And I'm going to talk about strabismus and myopia again, but something different. So because when we think and we talk about strabismus and myopia, the first thing we think about is these cases of huge eyes and this type of strabismus. But actually, and I don't have financial interest to disclose, actually, there are a wide amount of strabismus types that can be seen in patients with myopia that range from infantile, associated to prematurity, acquired esotropia with divergence insufficiency, the acute acquired comitant esotropia, Bielchowski type that was already mentioned this morning, sensory strabismus, and of course the one we just talked about in the previous session, the one associated to staphyloma and muscle path displacement. But how frequently can we encounter strabismus in patients with pathologic myopia? And one of the largest papers on this topic is the one published by Dr. Tanaka and co-authors at the Medical and Dental Tokyo University, who looked retrospectively into 636 high myopic patients from his myopic clinic. And they found that almost 20% of their patients suffered of strabismus. Of course, because it's done in Asia, in Japan, most of them were exotropic, which is not our situation in the Western Hemisphere, and almost 5% were esotropic. 16% of these patients also had vertical deviation, and in 2.5% of their cases, they found of strabismus fixus form. What type of strabismus is more frequently seen? And this depends, of course, on the part of the world you are working. For example, in the previous paper, you have seen that the exotropia was the most frequently one seen. But that's not what we see in the Western Hemisphere. And in the last International Strabismological Association meeting in Cancun, Mexico, we presented this paper where we looked into the clinical characteristics of our patients with esotropia and high myopia, and we evaluated the outcomes of the patients undergoing surgical correction. This was a retrospective study done between the year 2000 and 2022, where we only found 26 patients with esotropia and high myopia, with this mean refraction almost equally in sex, and most of them were children. You might ask yourself, especially living in this part of the world, only 26 patients in 20 years. But I come from this country, that's where I work, in Quito. We are right at the equator, and we live at 3,000 meters high. If you look at the Finnish meteorological webpage, where they explain in some parts of it the UV index forecast, and this is the UV exposure in different parts of the world, you will see that in Quito, the city where I work, at a certain day, at midday, we reach 15 UV index in a scale that goes from 0 to 17. Above 3, skin and eye protection is recommended. In Washington, D.C., the same day, at the same time, they only reach 5. So this, together with our genetic pool, makes that the prevalence of myopia is very low in our population. Of course, this is also changing as in the rest of the world. But in a study that we did in the year 2000 on over 6,000 children that we screened, we only found a myopia prevalence of 2.6 and high myopia of 0.16. So as you can see, our population is pretty different to the one you're used to see here. So among these 26 patients, most of them children, we found 8 patients that started their strabismus before the age of 1 as an infantile esotropia. 10 of those patients were born premature, and 4 received laser treatment for retinopathy of prematurity. The amount of deviation was very variable, between 15 and more than 100, but most of the patients had a deviation between 30 and 45 prism diopters. 8 patients had a displaced muscular path, as we talked this morning. This is one of them, one child of 18 months of age. Of the 26 patients, 19 were operated, and in 13 patients, only 1 surgery was done. 3 patients received 2 surgeries, 1 patient 3 surgeries, and in 2 patients, 4 surgical procedures were performed. This is interesting. Only 10 patients had a good result with 1 procedure, 10 prism diopters or less, which makes that we only had success with 1 surgical procedure in half of these patients. Which surgical techniques were utilized? In 13 patients, we did a resect or recess plication procedure, and in 6 patients, we did muscle relocation procedures. In 3 cases, we did the zigzag technique, elevating the path of the muscle. In 3 cases, we did a Yokoyama technique, but one of these cases had a previous zigzag technique done, and in 1 case, we did a Emmy Jensen technique. So what type of esotropia can be found or we found in our cases? 8 cases presented as a form of congenital esotropia. We found 2 cases of sensory esotropia, and in 16 cases, the esotropia was acquired. Some of the cases had more than 1 etiology or 1 cause. And let me finish my presentation describing one of these cases where we had multiple causes. We found multiple causes for her esotropia. This patient presents to me for the first time at 8 months with the history that she had esotropia starting the first months of life. She had an esotropia of 60 prism diopter with what I thought at that time only a right inferior oblique overaction. But what was peculiar at my examination is that I found this cycloplegic refraction at 8 months. So my first surgical procedure on her was a bimedial rectus recession with a fan and anteriorization of only the right inferior oblique. Postoperatively, she had a residual esotropia of 15 prism diopters with, of course, deviation also, overaction also of the left inferior oblique. 1 year later, the esotropia increased to 20 prism diopters. This is why I performed a second surgery consisting of a resection of the left lateral rectus of 6 millimeters and anteriorization of the left inferior oblique. And so 1 month post-operative of the second surgery, she was orthophoric but for near and distance, and we were very happy. But I kept seeing this patient, the myopia kept increasing. She was not very compliant with the left eye patching, so she had an amblyopia on her right eye. And 13 years later, when she was 15, she comes back with a recurrent esotropia of 35 prism diopters. You can see that the myopia kept increasing. And I performed a third surgery. I didn't have images of this patient, but I could see during surgery that the lateral rectus was inferiorly displaced. So what I did is I elevated the right lateral rectus after resecting in 5 millimeters, and I also elevated the previously resected lateral rectus. So she had 3 surgeries. And now she had a residual esotropia of 15 diopters, but she was happy with that, so I was happy also. But she comes back 10 years later, 20 years now, and she had a recurrent isotropia for distance and 20 prism diopters for near, with an axial length of almost 30 millimeters. Now I could obtain the images. You can see that the lateral rectus were not displaced, but remember that I already elevated those lateral rectus with a non-absorbable suture. But you can see that the superior rectus were nasally displaced. And this is why you will see that when she looks up, you can see, especially on the right eye, how the eye, when it goes up, it goes in, because the superior rectus is acting more as an adductor than as an elevator. So in this case, what I ended up doing, this is the superior rectus, I placed a suture, non-absorbable suture, 8 millimeters back from the insertion, and then here's the previous suture of the Mercian suture I placed on the lateral rectus. So I passed the suture next to this suture, and then I pull. This is the lateral border of the superior rectus, and this is the superior border of the lateral rectus. And with that, the patient was orthophoric, and when looking up, the eye did not go in. The question is now for how long, but now if she comes back 10 years later after, I probably will be retired, so this will not be my problem any longer. So to conclude, the strabismus in high myopes are more frequently seen than in the general population. General population up to 5%, in these patients up to 20%. Esotropias associated to high myopia can be due to different causes, as you have seen in this previous patient. First as an infantile esotropia, then as a sensory esotropia, and then she had also the muscle paths displaced. Management can be challenging. The success rate with one procedure is lower than in other forms of strabismus, and it can be recurrent, as in this patient. Surgical complication as scleral perforation is something that you have to consider when operating these patients. If no displacement of the muscle path, resect procedures are very suitable for these cases, but if significant muscle path displacement is present, muscle relocation must be considered in order to obtain the better results. So thank you so much for your attention, and please remember this ISA meeting in Buenos Aires next year.
Thank you, Dr. Andrea. Any comment or question? Just a question, Andrea, if you have a child who comes with esotropia and has myopia, so would you consider imaging to see muscle displacements, or you would plan your conventional surgery?
Like this one with 8 months?
Yeah, a child, an infantile, a possibly potential infantile esotropia.
I don't think this child, the one I presented, had muscle displacement at 8 months. Although in my previous talk this morning, I presented an 18 months a boy that had muscle displacement even at that time. But I wouldn't. No, I would not. But surgically, maybe you would like to see the muscle if it is displaced or not.
And one more question. So if we image a child with esotropia or any patient with esotropia, there would be a certain amount of nasalization of the superior rectus because the eye is inwardly deviated, and so depending upon where you're taking the cut or the cross section for the coronal image, you are going to have a little bit of nasalization. So how would you, like in this case, how would you, the lateral rectus was operated, so there was not significant downward displacement. So how would you grade now the amount of nasalization of the superior rectus?
Well, but you can study the movement, the eye movements, as you saw in this girl. When she looks up, the eye went clearly in. So you're right. There is a certain nasalization of the superior rectus normally, especially where the cut is. But you can, better criteria is looking at the eye movements.
Right. So motility is still extremely important for us to be able to.
The clinic is always sovereign.
Right. Thank you. Thank you. We'll have our next speaker, Dr. Angkor Wang, who is the Director of Neuro-Ophthalmology and Strabismus section of the Taipei Veterans General Hospital. He's currently a council member of the Taiwan Ophthalmic Society, the APAO, the APSPOS, and the ASNOS. So he wears a lot of hats. He's also done a PhD in neurobiology. So he brings an amazing amount of experience. He'll be talking on thyroid-associated strabismus.
Thank you, Professor Saxena. Thank you for inviting me here. And today I'm going to talk about the thyroid-associated strabismus. I think the diagnosis of TED will rely on the clinical examination, blood test, and also the opto imaging to find out the enlarged muscle. And the management of TED consists of two parts. The first part would be the medical treatment, and that includes the systemic steroid or external radiotherapy. And today we are focusing on the surgical management. Usually the timing for the surgical management is after the acute phase has resolved. And we will follow up the persistent diplopia for a minimum of 4 to 6 months until there is a stable strabismus measurement. At this moment, usually the thyroid function has been adequately controlled, and if the patient is going to have an opto decompression or thyroid operation, we will wait until they receive those operations. And the surgical principle for the strabismus in TED, usually resection are used whenever possible, since these muscles are already fibrotic and enlarged. For the hypertropia in TED, usually the first muscle to operate on is to recess the ipsilateral enlarged inferior muscle. And do remember to dissect the capsulopalpebral head from the inferior muscle to decrease the chance of postoperative lower lid retractions. For the methods of surgical treatment, traditionally we will recommend adjustable suture technique under general anesthesia with post-operative adjustment. However, recently I adopted local anesthesia with on-table adjustment, which has the benefit of no hospital admission, no post-general anesthesia discomfort, and there's wider range of adjustment on table. Look at the case. This is a 72-year-old female patient, and she had a 20% of the hypertropia in the left eye, and there's a moderate limitation of superduction in the left eye as well. And the important part is that we do have a pre-operative assessment in the clinic. We will check the distance between the limbus and the lower lid margin pre-operatively. The distance should be at least 6 millimeters to offer a large amount of surgical space during the local anesthesia. And during the operation, we will first give a local injection in subtenon space and then dissect the inferior muscle. And do remember to give a booster injection of local anesthetic agent into the soft tissue under the insertion site with a blunted needle. And hook the rectus muscle gently and to prevent discomfort, and lysis the adhesion between the muscle and the lower lid. And then cut the lateral adhesion as well, and then we will do the on-table adjustment. Preoperatively, she has a 20% of left hypertropia, and 1 week postoperatively, she is orthophoric in primary and down gaze position. So the key points for the on-table adjustment is that we should avoid patients too old with poor general condition, and also avoid patients with cardiovascular disease, and also high refractive error will prevent patients from seeing the target on table. So and also there will be, we have a preoperative assessment for enough operative space, and we should check if there is a 6 millimeters of distance between the lower lid margin and the limbus, so that we have enough surgical space and avoid those patients with too severe hypertropia. And the operation is done with a local anesthesia, and we do give a booster injection of the local anesthetic agents into the soft tissue under the inferior muscle insertion. And hooking the muscle with minimal traction time may prevent the discomfort for these patients. And we will, at final stage, we will do the on-table adjustment with alternating cuff test. And in the end of the surgery, we will verify the subjective fusion by the patients. The benefit for the on-table adjustment include easy to adjust in the operation and even with vertical muscle. And there's a less chance of muscle migration and no need for the hospital admission and no post-general anesthesia discomfort. The downside for the on-table adjustment including more pain and discomfort on oculocardiac reflex and difficult with patients with high refractive error and also difficult in patients with severe hypertropia. How do we assess the surgical dose? Since these muscles are generally very stiff and inelastic in TED, the initial recess of 2 to 4 millimeters has a minimal effect, and as the recession gets larger, additional millimeters will result in increasing large correction. So larger than normal recession are usually necessary for a smaller amount of deviation. However, smaller than normal recession are advisable for a large deviation. In my experience, usually if the hypertropia is less than 25 present diopter, single recession of inferior muscle is usually much enough. On the other hand, if the deviation angle is larger than 30 present diopter, please prepare for an operation on the second muscle. Which second muscle to operate it on? We may recess the contralateral superior muscle, especially if this contralateral superior muscle is also enlarged. However, sometimes we need to do the resection or plication of ipsilateral superior muscle. Plication or recession is not the preferred procedure for the TED because it may cause more inflammation or even more restriction, and there's also surgical difficulty to resect an already tight muscles. However, sometimes we may choose to resect or plicate the ipsilateral superior muscle if there is no enlargement of the superior muscle and if the patient is with severe proptosis or severe lid retraction in the upper lid. And also, if you check the muscle, recess the muscle, inferior muscle, there is a poor elevation in on-table adjustment, then plication of the superior muscle could be a better choice. Look at this 72-year-old female lady, and she have a severe left hypertropia, and she received the recession of inferior muscle for her first operation with 8 millimeters and another handbag for 4 millimeters. After the operation, the left eye is still very hypertropic and even more proptotic, and there's no improvement of elevation in the left eye. And she received the second operation by resecting the superior muscle for 6 millimeters. You can see that her supraduction movement improved a lot, and also the eye was less proptotic. So in procedure, many of recession rectus muscle, it may displace the center of rotation of the globe further anteriorly. If we combine the recession together with a resection of the antagonist, which may help to prevent the anterior displacement of the center of the rotation of the globe. Next, we will talk about the complication. Early overcorrection is a common sequela of inferior recession. Severe type of the overcorrection commonly caused by muscle slippage or IR myotomy. Mild or early overcorrection could be caused by overdose of combined R and R. For younger patients with mild limitation, remember not to plicate too much for the superior muscle. Late overcorrection may be caused by muscle slippage. We should judiciously dissect surrounding attachment and use a non-absorbable suture, which may prevent the muscle slippage. On the other hand, altered muscle dynamics, which may occur as a recent onset involvement of ipsilateral superior or contralateral inferior muscle, which may contribute to the later overcorrection. So in summary, for the TED strabismus, we should aim for a single binocular vision in primary and down-gaze position, and the recession are used whenever possible. However, normal muscle dose-response curve may not apply. On-table adjustment is recommended in TED patient if the condition is feasible. For residual hypertropia, we may choose to resect or deprecate the ipsilateral superior muscle, especially when there is a combined severe proptosis and a lid retraction. Early or late overcorrection may be prevented by careful preoperative clinical and imaging study and a judicious on-table adjustment. Thank you for your attention.
Thank you, Angkor, for a wonderful presentation on this very difficult and vexing subject. Any comments? Great. I hope you've saved questions for the end, because we hope to have some lively discussion then. My next speaker, who's been pushed down the order, is Dr. Rahul Bhola, who's a highly accomplished pediatric ophthalmologist and strabismologist. He's been elected as America's best doctor and top ophthalmologist consecutively for many years. He has numerous trials and research publications to his credit. He's an old friend. We go back long when I was doing my residency and fellowship equivalent at RP Center, and he'll be speaking on superior oblique palsy.
Thank you so much, Rohit. It's such a delight to be here. And Andrea, please don't let President Trump know that the incidence of myopia is so low in your country. Otherwise, you'll see all these planes going to Ecuador pretty quickly. So please keep it to yourself. This is a very broad topic, managing superior oblique palsy. It's beyond the scope of a 10-minute presentation, but I'll discuss some pearls that have helped me over the years. So, as we all know, superior oblique palsy is the most common cause of a cyclovertical palsy. And even though there are many cases implicated to acquired palsies, the most common cases presenting in childhood are congenital in nature. So it is important to recognize that many congenital cases may present, though, later in life. And why is that important? Because it should be differentiated from acquired cases, since the workup would be going on different pathways for both these. So it's important to recognize that early on. Majority of congenital cases can be picked up on the history of long-standing head tilt with facial asymmetry, which sometimes can be seen in what we call as the FAT, which is the family album tomograms. So it's always good to look at the old pictures of these patients just to see if it has been there for a long time. These patients typically will not complain of diplopia, and they might have a large vertical fusional amplitude. And if you do an imaging in these patients, you'll invariably see atrophic superior obliques and sometimes even absent superior obliques, as opposed to the acquired cases where you might actually pick up some localizing etiologies. So in any patient that I examine with superior oblique palsy, my first question is there any progressive diplopia with increasing hypertropia, with subjective complaints of torsion? If that's happening and it's getting worse, it always raises a red flag for some neurological issues. And I always like to look at other associated cranial nerve palsies or look for neurological signs and symptoms. And those are the patients that might benefit with an imaging at an early stage. I always like to obtain a field of single binocular vision in these patients, typically by Goldman if I can, if not by confrontation. It not only improves the diagnostic accuracy, but it also adds an additional measure of surgical success in these patients. I cannot emphasize enough doing a good cycloplegic refraction, which we do for any child that presents to us. For instance, in this 5-year-old who came to me with a bilateral superior palsy, she had like a +5 hyperopia in both eyes, and when we gave her glasses, her esotropia in primary gaze corrected significantly. So this might change the surgical treatment, right? You would do less surgery on the horizontals in this case as opposed to what you would have done if we didn't give her the right prescription. Always look for fixation duress, which is basically paralytic eye fixating, and more important for unilateral cases. And then you have to take into the secondary deviation into consideration as well while planning the surgery. And of course, like we discussed in the previous talks, the pattern of misalignment, reductions and versions are the most important. Bach's three-step test with Bilchowski's forced head test is an excellent test, but typically for a unilateral isolated supraoblique palsy. There are a lot of conditions where this test fails to isolate a single muscle palsy. And because of the time, I'm not going to go in detail on all of these, but basically any multiple muscle involvement, because this does not take into consideration oblique field measurements and torsion into account. So it's important to make sure that you're not making the diagnosis just solely on the basis of this test. Anomalous head position, majority of patients with supraoblique palsy will assume an anomalous head position contralateral to the side of palsy, although make sure that, be sure to check that really well, because some of these patients might actually have the head tilt on the ipsilateral side. For instance, the 6-year-old girl with a brain tumor with acquired supraoblique palsy and ipsilateral optic atrophy with poor vision in one eye presented with a paradoxical head tilt, which actually improved dramatically after surgical management. Torsion, we've all been taught in our residencies to check torsion, but I always like to check it both by subjective as well as by objective measures, because both of them give us different information. The subjective actually gives us the total torsional misalignment between the two eyes, whereas the objective gives us individual torsional misalignment between the two eyes irrespectively. And again, I cannot emphasize enough to look for reversal of hypertropia in side gazes, especially in the oblique gazes. It might prevent some surgical surprises, because you want to pick up cases of bilateral supraoblique palsy early prior to surgeries. Most of these patients will, of course, have a V-pattern esotropia, chin down head posture, and most importantly, the torsion greater than 10 degrees. Always look for torsion in down gaze as well, because that's where the torsion might be more than what you anticipate. So the general principles of management, one important principle of management is not to sacrifice good alignment in primary position and down gaze to achieve alignment in eccentric positions. So the size of primary gaze deviation and the pattern of incompetence determines the surgical plan, including the number of muscles and the quantification of surgery. So always look at the torsion as well, like we talked about. So let's talk about some case scenarios. We'll first consider a patient presenting with less than 15 prism diopter of hypertropia. So there can be 3 different cases that the patient can present with. In the first case, there might be increased the maximal deviation in the inferior oblique gaze, and in those patients you would weaken the ipsilateral inferior oblique. When there is maximal deviation in the superior oblique gaze, I always like to do an exaggerated force duction test. If the inferior oblique is tight, I like to weaken the inferior oblique. If the inferior oblique is not tight, I like to tuck the superior oblique, and the degree of tucking would depend on the laxity of the tendon. And then there is another scenario where the deviation is kind of even across the inferior gaze. And these are the patients where you always look for the contractures of a superior rectus. So you always do a force duction test during the surgery and then recess the superior rectus. Sometimes you can get away just by recessing the superior rectus alone for patients less than 15 prism diopters of hypertropia. Now keep one thing in mind though, when you're recessing the superior rectus, you're making the torsion worse, right? You're weakening the superior, so you're making the torsion worse. So you might have to temporally transpose the superior rectus tendon to take care of that. The other scenario where the hypertropia is greater than 15 prism diopter in primary gaze, if there is again increased maximum deviation in the inferior oblique gaze, you can weaken the ipsilateral inferior oblique and the contralateral inferior rectus muscle. The other scenario, like we discussed previously, where the deviation is actually, there is some residual hypertropia, or there's some hypertropia in the ipsilateral abduction. If it's greater than 10 prism diopter, always consider the superior rectus contracture, and we have an example we'll share. But make sure that if you're weakening both the elevators, so in this case inferior oblique and superior rectus, you got to be very careful that you don't do more than 2 to 2.5 millimeters of superior rectus recession. Otherwise, you'll end up getting elevation deficit. There's another procedure which I've started doing lately is the disinsertion of nasal 3/4 of the superior rectus fibers. And the beauty of that procedure is that it doesn't make torsion worse. So it's actually good for the torsion, but if you're recessing the superior rectus, you'll have to move it temporally. So this is the case of a 4-year-old girl who presented to me with congenital left superior oblique palsy with 20 prism diopter of hypertropia in primary gaze, increasing in dextroversion with a persistent hypertropia in the ipsilateral abduction, about 10 prism diopter. So one clue would be when you do a forced head tilt test, if there's a pretty exaggerated difference between the two, always suspect the superior rectus contractures. And in this patient, actually, there was not much excyclotorsion, so I decided to do an inferior oblique recession with small superior rectus recession with a slight temporal transposition, and it worked beautifully. I don't have much time left, but I'm going to just discuss a couple of case scenarios of symmetric bilateral superior palsy with inferior oblique overaction greater than superior oblique underaction. And in these cases, you will do symmetric weakening of inferior obliques, and you might recess the inferior rectus if the down gaze esotropia is greater than 15 prism diopter. In this situation, there is asymmetric bilateral superior oblique where you would do asymmetric inferior oblique weakenings, and you can also do a symmetric if it's greater than 10 prism diopter of hypertropia in primary gaze, and then recess the inferior rectus in the hypertropic eye. So this is a case where there is a 3+ inferior oblique overaction in the right eye and 1+ in the left eye. I did a recession of the inferior oblique of the right eye 12 millimeters, and I did a marginal Z myotomy, which I use quite a bit. It corrects about 6 to 8 prism diopter of hypertropia in the left eye with an excellent result. So I think my time is up, but I can...
yeah, just complete.
Okay, so I'll complete that. So the last scenario is surgical management of symmetric bilateral superior oblique palsy where superior oblique underaction is greater than inferior oblique overaction. Again, if it's less than 10 prism diopter of hypertropia in primary gaze, I do bilateral superior oblique tucks, especially when there are large hypertropias in the side gazes. And then I do bilateral Harada itos if there are small hypertropias in side gazes. And then I always add an inferior rectus recession if esotropia in down gaze is greater than 20 prism diopter. And if the hypertropia is greater than 10 prism diopter in primary gaze, I do asymmetric superior oblique tucks, adding the inferior rectus recession in the hypertropic eye. So the last case is a 9-year-old girl who presented with bilateral acquired superior oblique palsy, secondary to a pilocytic astrocytoma removal, and she had asymmetric superior oblique underaction with right greater than the left, and about 12 degrees of excyclotorsion. So she did have about 15 prism diopter of esotropia and down gaze, but I decided to do a bilateral asymmetric superior oblique tucking without doing anything for the esotropia in down gaze. I should have, because she came back with a residual 15 prism diopter of esotropia and down gaze. That's when I did a sequential surgery, a second procedure with bilateral inferior rectus recession, and she had an excellent result. So to summarize, every case of subregular palsy needs an individualized approach with customization depending on the primary gaze misalignment and the pattern of incompetence with torsional measurements taken into account as well. Families should be prepared for sequential surgeries in case of suboptimal results. Thank you so much.
Thank you, Rahul. We'll go on to the last talk before we open the floor for questions. We have Dr. Swati Fulgire, who's a colleague with me at RP Center. She's been practicing strabismus and neuro-ophthalmology for over 20 years now. She'll be talking on monocular elevation deficit.
Let me begin with thanking Professor Saxena and APAO for this opportunity. It's a pleasure to be talking among the stalwarts of strabismus here. So I would be talking about monocular elevation deficit, and of course the diagnosis is not so difficult. It is the limitation of elevation with normal deductions in all other cases except for elevation in abduction. It is frequent cause of hypertropia, mostly congenital, and is associated often with ptosis, pseudotosis. So there can be cases of ptosis, pseudotosis, and Marcus jaw winking phenomena. As you can see here, so all these presentations can be visible, and patients should know that the ptosis surgery has to be done later. Most of the time when patient comes to us, they expect that the ptosis surgery is what we are going to correct, but as a strabismologist, I think it's important to make clear that we will be correcting the strabismus part and ptosis part will be corrected later by the plastic colleague. The important thing to differentiate it from is Brown's syndrome, where you have limitation of elevation in adduction. So that's the difference. As you can see in this case, that there is a limitation of elevation in adduction vis-a-vis the case below, where you have limitation in abduction. So it's very important to differentiate the two, because the pathology in the Brown's case is in the superior oblique muscle tightness, and we need to deal with it vis-a-vis monoocular elevation deficit. We need to take care of the superior rectus. So the acquired causes could be floor fracture, where you have entrapment of soft tissue either, or inferior rectus muscle, which will lead to the limitation of and restriction of movement in elevation. Thyroid orbitopathy, as dealt with by Dr. Wong, is the another important differential that needs to be kept in mind whenever we are dealing with the acquired monoocular elevation deficit. So I'll be mainly talking about congenital MED, and that's the focus of this talk. So we have three types of congenital MED. Type 1, where you have a primary inferior rectus restriction associated with poor Bell's. Type 2, where it's a primarily SR palsy and Bell's may still be poor. And type 3, where you have supranuclear type with good Bell's and negative force reduction test for inferior rectus. So the management, most of them are, because they are congenital cases, they are often associated with some or the other refractive error or amblyopia, and it's important that we need to take good care for the management of amblyopia before we do surgery. The indication for surgery is often cosmetic, and the primary deviation in the the deviation in the primary gaze often associated with abnormal head posture if there is binocularity. So before we proceed on the surgery, there are certain parameters that we need to evaluate. The most important one is the limitation of movement in upgaze, how much the movement is limited, the amount of deviation in the primary gaze. As Dr. Bola emphasized, that we may not be able to correct the deviation in all the gazes, and therefore we should concentrate only in correcting for primary as well as down gaze. We should also look for the amount of ptosis, the presence and absence of Bell's phenomena, tightness of inferior rectus, and if there is some force still can be generated in superior rectus or not. So the management, as I said, depends on the variable factors, and the most important of them is the force reduction test for inferior rectus. If your inferior rectus is tight, the choice of surgery is none but the inferior rectus recession. The amount of recession will definitely depend on the amount of tightness, and then can be titrated intraoperatively during the surgery. So at the point where you have minimal restriction, you will have to leave your inferior rectus at that point. So this is a case where we have limitation of elevation in the right eye, and after doing the inferior rectus, you can see that some patient achieved good vertical alignment as well as some movement in elevation. If your force reduction test is free, that means it is negative, the NAPS procedure is the treatment of choice, right? And how do we NAP? It's just a plain simple transposition of the horizontal recti. So you hook the muscles as we do with any other strabismus surgery. The idea is to do a good dissections, cut the intramuscular septum nicely so that we can pull the muscle towards the superior rectus. In this case, we have augmented the NAPS transposition with the posterior fixation suture to enhance the effect of the transposition. The same thing can be done with the other horizontal recti. So this is a case of type 2 MED, which is primarily a superior rectus palsy associated with very, very poor elevation, as you can see in this case. So the patient underwent the NAPS procedure and had a good alignment in primary gaze, and definitely there was improvement in elevation. In certain cases where the SR function was good, the elevation was good preoperatively, and the deviation was very less, we tried to do SR plication, and as in this case, we can see that there's a right MED along with the poor elevation, but as compared to the previous cases, the elevation in this case was relatively better, and therefore we did SR plication, and the post-op results are satisfactory. This is another case with good SR action along with good Bell's phenomena with a very small vertical deviation in primary gaze. So doing SR plication in such cases may help, provided your vertical deviation is extremely small, less than 20, with a good SR action. Along with a monocular elevation deficit, we may sometimes have associated horizontal strabismus, and there are ways to deal with that horizontal strabismus as well. So you can do modified naps. That means the horizontal recti muscles can be recessed or resected depending on the ESO and exotropia. So that is one option. The another option that has been described in the literature is partial muscle transposition. That means that the superior half of the muscle is used for the transposition, while the inferior half of the belly undergoes recession resection procedure to cover the horizontal deviation. That has also been described. The other way is to do, if the horizontal deviation is too large and may not be taken care of by one eye, we may have to do the correction in the other eye. We have also tried to do a modified naps where we did the transposition of the resected muscle without recessing the contralateral muscle. So as in this case, you can see that the patient has very large exotropia here with MED, and first surgery, because the exotropia was too large, it was difficult to correct it with the same eye. So we first did the naps with posterior fixation sutures, and followed by the RNR procedure, recession plication procedure in the contralateral eye, and you can see that the patient has achieved good alignment postoperatively. However, in next case, you can see that there is some esotropia in the right eye along with MED. The amount of esotropia was not very much; it was around 25-30 prisms. So we wanted to have do the naps along with the lateral rectus resection without recessing medial rectus. So this is the result we achieved, and this photo has been shared by a plastic colleague after doing the ptosis surgery. So you can see a good cosmetic result was found there. So we believe that if we transpose the recessed muscle, we are actually weakening the elevation effect of that transposed muscle as well. So without recessing the muscle, the transposition may be more effective. But it may not work in all cases. So in cases where you have more deviation, large horizontal deviation, you will have to do the surgery in the other eye. So we published our results and in different types of MED and different types of surgeries, and this is what we found. We found that the inferior rectus recession more or less gave us the average correction of 20 prisms. NAPS procedure alone without any augmentation gave us 25 to 30 prisms. So therefore, whenever we have a vertical deviation more than 25-30 prisms, it is better to augment it with posterior fixation suture. The augmented naps gave us around correction of 40 prisms. However, when we did the horizontal muscle surgery along with the naps only by doing resection, we found that it gives us an average correction of around 30 prisms. And that's what we advocate, that whenever you have a horizontal deviation which is less than 30, you can do a single muscle resection and not to recess the other muscle. So to conclude, patient of MED may present with varying degree of deviations and may be associated with different orthoptic manifestation. And management should be tailored according to the clinical manifestations, depending on which we can choose the surgical technique, which is very important for achieving the useful alignment. Thank you.
Thank you, Dr. Swati. A wonderful presentation on monocular elevation deficit. I'll request you to come join us on the dais. Any questions from the house before we take a few questions among ourselves? Anybody has any queries? I know the talks were crystal clear, but I'm sure there must be some. I do. Yeah. Yeah, Dr. Manjula. Mike, could you? Uh, it's being recorded, so.
Actually, I have a few points to make. One is if younger child, yes, some small amount of recession and SRT will improve your abduction. As the child becomes older, if you really want to change the face turn as well as improve motility in abduction, then I think something has to be done in the contralateral eye. It could be just even only an MR fade in, but you need to do it. Only then that abducting force is better and even your primary position alignment is better. What is your take on it? This is my experience.
Okay. I have rarely operated on the other eye. Earlier we were doing medial rectus fardum to improve, but generally I have found muscle transpositions to be fairly effective. In Duans, I don't even put a posterior fixation suture because we've had a bit of hypotropia with that. So I just do a muscle transposition with a medial rectus weakening. And one thing I'll note is, I've noted is that the head postures are more than the primary gaze deviation that you see. It could be probably the most comfortable position, but I don't know. But I haven't operated the other eye so much. Anybody managing on the other eye? So I guess sometimes the habitual head posture does tend to come back in an adult, so maybe, but like I said, I don't have enough experience. Yes, Viren.
Yeah, I have a question for Dr. Saurabh first. So, you were telling about the Botox in esotropia in children with developmental delay. How has been your long-term outcome with them? Do they recur or do they stabilize?
Thank you for the question. These are a very difficult set of isotropias to correct because a lot of them consecutively become exo anyway, which is why if you go in early for surgery, then you just end up with a consecutive exotropia, which is why we did toxin. And I remember one of the parents, and they do really well because what we think happens is when you put in the toxin, they go exo, and then gradually the toxin wears off, and there's a time when they're orthotropic, and we hope that the brain then sort of latches on and they don't let them go back in ESO. And at least one kid needed 3 injections, which the third one I was very, very reluctant to give, but the dad forced me to, and I was glad I did. But the others only needed 1 injection, and they were straight or nearly straight for the majority of the time, and I didn't have to operate on any of them, so I consider that a success. So within 3 weeks, you really want to see the exo after 3 weeks. If they haven't, then it's not going to work in my opinion.
What's your average number of injections, say, for infantile esotropia?
I usually don't do more than 1, I have to be honest.
Okay, so a good percentage of them get aligned just on 1 injection.
No, I think it depends on, so there's a few subgroups. There are those that have a very large angle esotropia, and I will tell them you will not get aligned, but you will be less than what we started with. Is the ones that are less than 30 diopter the one I hope for alignment. Some of them do really well. Depends how early you get them, and we don't always get them before 1 year of age, although we would like to.
Great. Yeah, Virendra, you have a follow-up.
Yeah. So I think we discussed about the number of injections. One more thought, maybe a question to Professor Wong as well as to all of you. I have heard and possibly experienced myself also, like in TED after the stabilization, we usually do like IR for a hypotropia, but there are patients who don't improve, and then when you go and do the contralateral SR, it improves. What my point I'm trying to say is that we do weigh in the imaging that which muscle is bulkier and thicker, but there are some reports, I have heard the cases wherein people have said that it is not the bulkier muscle that might be if the main culprit, but it might be the fibrotic contralateral muscle. So any thoughts or experience with that?
Dr. Man. So how much are you weighing in the bulkiness of the muscle when you're planning surgery? And like essentially how long do you wait, and is the bulkiness so important, or as Virendra puts it, you're more concerned about fibrotic? Wait for before planning surgery?
Usually I will wait until the several months when the eye is not red in condition, and I assess the angle deviation angle for 2 months, every 2 months. And if the patient had been stable for 4 months, I would go for the surgery. And that's my practice pattern. And can you repeat the?
So more specifically, if I were to say, like, we have a right hypotropia and IR is looking thick, bulky and fibrotic, but at the same time the superior rectus in the other eye could also be pathologic. So would you weigh in doing the IR only first, or you would go ahead and do the superior rectus recession in the contralateral eye?
Usually, if the deviation angle is over 30 prism diopter, there's a high chance that you won't be able to recess alone to correct the deviation. So at that time, I would consider the second surgery. And in this condition, if the patient has been associated with a lid retraction in the same side, then superior rectus plication would be a better choice. And on the other hand, if the superior rectus is already enlarged, then it won't be good to resect or plicate this muscle again. Then I would go for the other eye. Since I found that although the plication is very effective for you to improve the supraduction after the operation, however, sometimes it will cause the patient cannot depress their eye after the operation. So the surgical dose for superior rectus plication should be as minimal as possible. Usually, I would do maybe 3 or 4 millimeters, and no larger than 5.
Okay. When you keep them on adjustable, you keep them in the post-op period also adjustable, or you would prefer only intra, because the risk of recession of the inferior rectus over time, if you keep them?
Both way. If I can do the local injection, I would do it on table. And if the patient have many contraindication to receive the local injection, I would do it post-operative adjustment.
For monocular deficit, yeah.
You always use a non-adjustable suture, as you had said in your talk, when you operate on the inferior rectus?
Not really. If the condition is like if I adjust it on table after the operation, I will just close the wound. I won't do I just adjust on the table only.
Yes.
Okay. MED,
yeah, Kalpit, come, Dr. Kalpit.
For MED, like as you told, like only doing MED with the ISO, lateral rectus resection with the upward transposition. So would not it affect the palpebral fissure? Already there would be some ptosis element would be there. So can we do not the recession, but we loosen the medial rectus and transpose in the upper part with the same amount from the limbus?
Yeah, that has been described, very well described in literature. But what we are trying to say here that, you know, if you do a recessed transposition of a recessed muscle, you are not just weakening the esotropia. Of course, you would be correcting that, but we are also weakening its elevation transposition effect that you were supposed to get if you don't do the recession. Right? The amount of elevation that you achieve without recession will definitely be more than the amount of elevation that you achieve with recession.
Okay.
Having said that, as you pointed out that there will be palpebral aperture, but we have seen that if you do a good dissection, which is necessary whenever you are doing a transposition procedure. So a good dissection, cutting all intraseptal septal attachments, cutting all other attachments is very, very important whenever you are doing transposition surgeries, and that definitely will not lead to any palpebral aperture change.
So we are not doing the medial rectus recession, but we just
you transpose it like the thought
same.
behind this concept is that you tackle one vector with one eye. Make sure that you don't have significant vertical when you want to tackle the other eye, because the other eye horizontals can be tackled because that is a comitant strabismus. But the incomitants that you have in the monocular elevation deficit, you make sure that you get it, you eliminate to the maximum possible the vertical deviation. Because if you're correcting a large horizontal the other eye, you're struggling to then correct the vertical, then maybe you may use the inferior oblique to, you know, create an anti-elevation or things like that. But that's what, correct vertical in one go in one eye, and then wait. I mean, you could do the horizontal, residual horizontal. Yes.
Thank you, thank you. You know, it was all great talk. By the way, a great dissections, I think, is the key. I agree. But Dr. Jain, real quick, I agree with you. Usually one Botox injections is sufficient. I'm actually, to my surprise, also, I anticipate doing multiple Botox injections for these esotropias. But from my experience, one is adequate. But only thing I would like to add is that in patients with the esotropia greater than 30, typically 40% doctors, I do augmentation. So I do muscle surgery with the botulinum toxin augmentations, which actually have been very happy with. Any comments about that?
So no, I agree, Donny. So going by the Campomanes paper, the average number of injections per kid was 1.3. So I agree. That's what studies have shown us. So I have used toxin along with medial rectus recession, which is my preferred method for infantile esotropia. But if it's 40 diopters, I would do a bimedial anyway. But anything over 50 or 60, and that's the cases I do by augmentation. The reason for that is it's just gets a bit of unpredictability into the mix when you put in a toxin. You don't know what you will get. So Rohit, my colleague, is sitting there. We had a child exactly like that. We did the toxin at the same time, and they went 75 XT. For a long time. It's what, now 5 months, Rohit, and we've been seeing this family every week or every month, and we can say it'll be fine, and they've come in to about 15 XT, but they've stopped. So that's just scared us a little bit about augmenting.
I agree with you. If I'm considering 3 muscles versus 2 muscles with augmentations, I always go for the augmentations with 2 muscles. Yeah. Thank you.
We'll have Vivek and then.
Yeah, I just wanted to add regarding my experience in patients with myopic strabismus fixus. So if you look at the yield of MRI to get the change in muscle path or the angle of centroid between the 2 muscles is very less in patients with mild to moderate form of MSF. Until and unless they are very large and extensive, then you would get very classic finding on MRI. Otherwise, the best way to confirm is on table, look at the path of the muscle. So that's the best way to confirm it. However, apart from iso-hypocomplex, if you do have exo-hypo or like exo-hyper or iso-hyper, then probably until and unless we do a MRI the way Dr. Dimmer does it, like a very critical quasi-coronal cuts, looking at the angle of centroid and at the microanatomy at the orbit, probably that would help to confirm, and then you can take a call. But in a larger angle, probably I would suggest it's not required to do MRI or a CT. Thank you.
Agree.
She mentioned it's the clinical appearance that is probably more important. Yeah, Sumita. I think we're running short, so we have a couple of more questions.
One question for Dr. Swati. Did you find any torsion when you do only one muscle resection and shifting it up in MED?
Not really, but I'll admit most of them are congenital and amblyopic. So subjective torsion is generally not there, and objectively I did not
found any torsional element. Second, a note about bilateral surgeries for Duane's. You say you hardly do any bilateral surgeries.
No, for unilateral Duane's operating the other eye. Bilateral Duane's,
so,
you do bilateral.
If it is a large angle ESO and no other,
okay.
I have done probably asymmetrical bimedial recessions, and they have given good results.
Yeah, no, of course. I mean, I would tackle the ipsilateral eye first, maybe do a transposition with an MR recession, and for the residual, yes.
You said nobody is doing
yeah, I mean, I didn't, no, I didn't mean that. I didn't mean for the larger angle. Was only specifically. Yeah. Yes. Yeah, I think we have one more question.
Yeah, just a quick question for Dr. Saurabh Jain. For those kids where the Botox doesn't work and you plan surgery, what's your waiting period? How long do you wait for?
That's a really good question. It has to be more than 3 months. So I had a 6-nerve palsy. I did a toxin, nothing happened, and this patient made me do the Nishida and an MR recession, and they went completely XT, and there was no adduction at all. So the toxin had worked, just the muscle was so tight, I couldn't see the effect. So I really got burned. I never do toxin surgery at least 3 months, if not more. They need to come back to the pre-injection angle, or they need to be stable for 3 visits. at least 3 months after surgery.
And that's also for your babies, infantile esotropias? You'll
So
wait for 3
infantile
months?
esotropia is the same principle, but this is a slightly different thing. What you're trying to do there, either to align the eyes or reduce the angle, but again, and so, you know, again, no, you have to wait for 3 months for it to wash out before you do anything.
Rahul, just one question for you. Any experience on infero-nasal transpositions of the inferior oblique for superior oblique palsies?
You know, I used to do that initially, but it didn't work in my hand for some reason. So I've stopped doing that completely. What's your experience on that, Rohit? Yeah.
So I really enjoy and like doing that actually. I do that, I'll do the infero-nasal transposition when I have a larger torsion to correct.
Totally.
And I do the anterior positioning or the iliac and nanking, or even anterior positioning it even anterior to the inferior rectus if I have a larger vertical to correct. So that's how I would, I mean, and we get some great torsional change. In fact, it almost like a weak superior oblique. So
I remember having published a paper with you on that
yes,
way
yes,
back.
We had that. Yeah, that was nearly 20 years ago.
Yes.
So I think not too many questions anymore, and we're on time. So I thank you everybody for coming for this wonderful session. It was extremely enjoyable for me, and I hope it was for you too. Thank you for my co-speakers. Thank you very much.
Thank you.